In 1999, a unit of the National Academy of Sciences called the Institute of Medicine, probably the most prestigious private organization in medicine in the United States, the IOM, came out with a report called "To Err, ERR, is Human." This is the most important medical document, and there have been many, but this is the most important medical document of the 20th century. And in that document, the Institute of Medicine looked at closely at studies, intensive chart reviews in New York, Colorado, and Utah, and said that there were 44,000 to 98,000 medical deaths in the United States annually. That's a lot. That's a lot. That would have been the 8th largest cause of death at the time. There was publicity that went out in the media that said that was the equivalent of a jumbo jet crashing every day for a year. It's an astonishing amount of human carnage. And it did create a lot of media for a time. It turns out that it's low, and computers have told us that. Now there have been analyses of charts using something called global trigger tools. Global trigger tools are electronic algorithms that appear in electronic health records that show errors. And some of the errors are not necessarily obvious. For example, Josie King, she had a medical error. She was over-opiated in a hospital, and she had to receive a drug that we all know about from the heroin epidemic called Narcan, or naloxone, which is an antidote to opiation. That is evidence of a medical error. So the new studies use these global trigger tools. Then they extrapolate them. They're usually you can't do it for the whole United States. So they do it in various regions and then extrapolate to the approximate 35 million hospital admissions we have per year, and they come up with this number of deaths, which is shocking, which is third to heart disease and cancer. And the profession accepts that. Anybody knowledgeable, well, just about everybody knowledgeable in the profession says, yes, we have a problem, and what are we going to do about it? Now, as I said before, we don't know, it could be even greater than that, because the estimates to date have not included diagnostic error. Diagnostic error, when analyzed, appears to be independently the greatest source of fatalities. Now, the leader of the largest study of diagnostic errors, the principal author of the British Medical Journal study, of the longitudinal study of the National Practitioners Database, 25 years of data, says that we know that there are now at least 100,000 and as many as 500,000 diagnostic error deaths in the United States. They're hard to get our arms around because they happen in doctors' offices mostly. Hospitals are not highly regulated environments. You might think that they are, but they are not. They are, as I said last night in the panel, it's not a regulatory environment, it's an accreditory environment. And that means that an accrediting agency, usually an august body called the Joint Commission, comes around every 3 years and looks at the hospital and some of the charts. Not good enough. But it's even less regulated in your doctor's office. And that's a matter of concern. What are our big other errors besides diagnostic error? And before I leave diagnostic error, I want to say that the Institute of Medicine, that very prestigious body, that unit of the National Academy of Sciences, into Error is Human, did not analyze diagnostic errors. And that's considered a flaw. Why did they do that? I can't tell you. I've talked to David Newman Toker about it. He's a remarkable medical researcher. He's a neurologist also. His body of work is outstanding. He's one of the, probably right now, he's on a par with Peter Pronovost as a leader in the drive against medical errors. And he's at Hopkins and has impeccable credentials and does very, very outstanding research. Why? Well, the soldiers of medicine, the salt of the earth types, the most numerous are the people in those doctors' offices. And there's some thought, and I talked to him about it, maybe they didn't want to offend those people. Maybe they didn't want to say, hey, you're just not getting it right, and people are dying as a result. And indeed, there is some pushback from them. And I know this because recently I wrote an op-ed piece for the Wall Street Journal, and I wrote about this to some extent. And the pushback from the doctors, not all of them, but the majority of them, was very angry. Why Wall Street Journal are you letting a trial lawyer write about this? He must be a malpractice attorney. Let doctors be doctors and we'll be fine. Don't regulate us. Things like that. Very disturbing to me. But perhaps that goes with the territory. I mean, I'm not upset about it, but you could see that there's some resistance. Okay. What are some, now, in terms of, I'm going to talk for a minute about diagnostic error. We know what are the problems. Doctors diagnose alone. They don't diagnose in teams. It's not like being in a surgical theater where the nurse provides the instruments, anesthesia provides obviously the sedation and the blood products. Everybody has a role. And everybody can nowadays stop a surgery if necessary, if they see the doctor about to saw the wrong leg off or something. They can do that. That's all good. There are no controls when the doctor diagnoses. And doctors, one problem that we know has to be done, sort of a re-education function, is called debiasing. Doctors, good doctors, have biases. They have very serious biases. Some of them are risk takers. They want you to go in and have the most radical procedure because they think you'll you know, high risk, high reward. And it's the way they do things. There are other biases that are quite serious. One is that women aren't having heart attacks. They'll send a man to the hospital to get angioplasty in a second. The woman's not having a heart attack. She's not having a sharp chest pain or whatever. It's a very serious bias. So we have to engage in debiasing. We also have to bring the teamwork of surgery into the doctor's office. When you say, well, my doctor's there by himself, even in an urgent, like in an urgent care place, he or she is just doing their shift. Who are they going to talk to? What are they going to do? Well, the answer is the three worst letters in American medicine are FFS, fee for service. The next three, which are related, are CPT, current procedural terminologies. They're related. Doctors often don't know what they're seeing, what they're doing. They know they may need other tests or procedures, but the billing codes don't allow them to pay for early conversations with people who know the answer or know what tests to apply, like pathologists, like radiologists who know about these burgeoning imaging technologies, who know about these probes at the molecular and genetic level. Doctors, your clinician doesn't really know. He's in the dark about it. He or she will just prescribe or not prescribe on a whim. That's really bad. You have to watch that. So what we're trying to do, the patient reform groups particularly, is change the fee-for-service system so there are CPTs so that the doctor can brainstorm initially with the specialists and everybody can get paid. And Medicare is looking at this right now. It will probably change. It's vitally important. It's vitally important. Okay, so those are two things. Make it so doctors don't have to diagnose alone. That's really critical. Do it as a team, debias them, and it is thought, though we don't know for sure, that diagnostic error, which is a profound problem, will go down.